So thanks so much to the All Ireland Institute for supporting this, and a very, very special thank you to my colleagues, my panelists who are all dear friends and colleagues, because, you know, this is, I kind of just mentioned it to them and they all have turned up. So I didn't think that this many people would be interested in this. So what I've done is try to kind of answer the questions that I had, so that when I am in conversations with families on telephone and in person, that I could answer the questions that parents are bringing to me. I just want to kind of, I suppose, put one caveat around this. I am a pediatrician and I have looked after a handful of children with COVID. I have friends and colleagues who've had COVID, and I, like many of us, know people who've died from COVID, but I'm not a public health expert, I'm not an intensivist, I'm not an adult respiratory physician, so I'm really speaking to this from my experience as a pediatrician. And I framed it by kind of posing some questions and then trying to answer them with the evidence. So Aidan McKiernan has taught me that we need to give the bottom line up front. So I'm going to tell you now what I'm going to talk to you about today. So we know that children are much less likely than adults to get infected with COVID. We know that when they do get infected, they are less severely affected than adults. We know, and this is really important, that they are not the vectors that people spoke about, and that children with complex medical needs do not appear to be at significantly higher risk of severe disease. And we'll talk a little bit about what the evidence is for that. What we don't know, and what I can't answer, is I don't know if there's going to be a second wave. I think there probably will be. I don't know when and if a vaccine will be developed. Like, I'll tell you that I'll be first in the queue for it. I don't know what schools are going to look like in September. And I really don't know, but I do worry about the long-term effect of this prolonged lockdown and absence from school on children and families. So what are the coronaviruses? So they are a group of viruses that were first identified in the late 1960s. And many people think that they're called coronaviruses because corona being crowned, but they're not. This is your fact of the day. They're actually named after the image of the corona of the sun when you look at the sun in a solar eclipse. And there is a number of coronaviruses that were known to be human coronaviruses that cause common cold. So we've been testing for versions of coronavirus for many years. But what's different between with COVID-19 is that this was a virus that typically affects animals and has mutated, transmitted or moved from humans, from animals into humans, and now has mutated to allow transmission between humans. And that is similar to, or has happened before in SARS, and in SARS in 2003 in China, and the Middle Eastern Respiratory Syndrome, which was an epidemic coronavirus in Saudi Arabia in 2012, which had really high fatality, 35% fatality rate. So what the coronaviruses come from animals, it's mutated, started infecting adults, and then further mutated to allow humans to transmit between themselves. So my first question, really importantly, because is this all fake news? Because when we look now at everything that's happened and the effect on our lives, and we kind of, you know, at times you can suddenly think, was this all a fuss over nothing? I don't think it was. And this is just showing us, to remind us that of the extent of coronavirus in the world. This is data from Monday, so that there's been over 8 million coronavirus cases worldwide to date, and 25,000 cases in Ireland. To put this into context, there was only ever 8,000 cases of SARS. So this is really is truly a pandemic. And the mortality rate, both in Ireland and internationally, is about 0.5%. And to show you that I'm not sharing fake news, if you know, PubMed is a huge database that holds all scientific and medical literature, and they have a sub-database called LitCovid, where they are hosting all of the available literature on COVID-19. And there is a huge amount of data. There's over 20,000 articles already hosted on LitCovid, and 760 of them relate to COVID in children. And I have to tell you, I feel like I have read almost all of those 760 articles in the last week. But this is a really, really good resource. And the other piece to say is that all of the huge big international journals, the Lancet, the New England Journal, have taken down the firewall for COVID-related scientific articles. So the articles are all freely available to anybody who wishes to look for them. So my next question, do children get COVID-19? and they certainly do, but across the evidence tells us that they are much less frequently affected than adults. So if we look at Irish data, 20% of our population is under 14 years of age. We've got a very, very young population. We've had 25,000 cases of COVID in Ireland, but only 490 of those cases were children under 14, and that's less than 2% of all of the cases. Then if we think about the severity of COVID, I think this Irish data shows us what I'm going to talk about later, which is that out of the 490 cases, only 37 of those children were admitted to hospital. We've had 2 admissions in Ireland to PICU. One was a child who had had recent neurosurgery and actually acquired COVID in hospital, has recovered, and I believe the second child had a very complex congenital heart disease, but I'm not as clear about the second case, and there have been no COVID-related deaths in children in Ireland to date. And this is replicated internationally, so this is data from Italy. It's data from quite early on, so before the schools were locked down in Italy, showing that only 1.2% of cases in Italy were in children under 18, and they had no deaths in Italy. And then we've got some data from Iceland. So Iceland, one of the only countries in the world, along with New Zealand and Australia, which have really effectively got rid of COVID from their population. And there's lots of really interesting things about Iceland. Safest place in the world to go as a tourist, healthiest diet in the world, and also probably the country that dealt with SARS most effectively through a really, really intensive testing and tracing program. So Iceland were the first country that picked up that people returning from skiing in Austria were coming back with COVID, and they notified the Austrian government about this, and the Austrian government chose to ignore this information and continue to allow people to go to ski resorts for weeks afterwards. This has led to a big huge, big international case now against the Austrian government in this regard. But meanwhile, what Iceland did is they went and they tested huge proportions of their population. So 6% of the Icelandic population was tested for COVID. If you look at their targeted population here, these are people who had been in close contact with a confirmed case or people who returned from travel abroad. And in that targeted population, almost 14% of people over 10 years of age were positive for COVID, but only 6.7% of children were positive. And then if they looked at, then they also screened a percentage of the population. So these are people who are supposed to be asymptomatic, and they got no cases in children under 10 and 0.8% in people over 10. I think this data also shows you that actually when we look at the low rates of infection of COVID, it is as children go through adolescence up towards late adolescence, their rates of infectivity are become closer to the adult rates, but in young children the rates are low. And then in Germany, in Baden-Württemberg, they did seroprevalence. They checked for immunity to COVID to see had they been, what percentage of the population had been infected with COVID. In this study, they did child and parent pairs. So every adult tested here has a child living in the house with them. They have a 1.3% seropositivity, so 1.3% of their population had been infected with COVID, but the children were half as likely as adults to be infected. And they've done similar studies in across Europe, in Switzerland and in Spain. And the disappointing news is that any place they do these seroprevalence studies where they think they've had this huge outbreak and the rates of positivity is only between 1% and 2%. So we are a long way off any idea of herd immunity. So then my next, the question that I was particularly interested in is, are children vectors? And we think about, when we had the early lockdown, we think about the signs outside supermarkets, saying that children weren't allowed into the supermarkets. We think about children being stopped in parks and screamed at on the streets by elderly people, where people were saying they were vectors and they needed to stay away from other people. And in fact, that the evidence shows us that they are not. So that transmission from children is possible, but really rare. And the main driver of the COVID-19 pandemic is from adults. So it's adult to adult and sometimes adults to children. We've got some really nice Irish data about this. This is looking at the 6 people with COVID-19 within school settings. So if you remember, the very first confirmed case of coronavirus in Ireland was a 14-year-old boy who had picked up COVID skiing. He was in school for a full week before he was tested. After he was tested, he went to band practice, and at that band practice went into a smaller group with a smaller subgroup of the children into a tiny room, and they practiced their wind instruments in that room. So use of wind instruments is a really high risk activity if you've got COVID. We know that when this boy was initially diagnosed, he had very, very, very high viral load, but he didn't infect anybody else. In fact, he was living in a household with his entire family, and nobody else in the family had COVID. And the similar is all of those. So he's one of those three children. There's another primary school child, another post-primary child who sang in a choir, again, another high-risk activity. And there were over 1,000 contacts with those 6 patients, and nobody transmitted to anybody else within a school. Very similar data from New South Wales and Australia, 18 cases within schools, no secondary cases within schools. And this is a Dutch article, which I have to admit is actually in Dutch. So I haven't read the entire article, but this is a illustration from it. And what this illustration is showing is that if you look here at the infected people, so these are children under 15 with infection, they don't tend to infect anybody else. While if you come up here to people in their 40s and 50s, when they are infected with COVID, they tend to infect a lot more people and tend to infect people within the same age. And finally, this is a systematic review from Sweden telling us that children are unlikely to be the main drivers of COVID-19 pandemic. So we have excluded our children from school for over 3 months when probably they were not going to infect anybody. So what are the symptoms of COVID-19 in children? That we know they have a milder disease. They very rarely require respiratory support, and their mortality is very low. We know that in adults that typically people present with respiratory symptoms, but you also have some of these systemic difficulties. So that fever, cough, and difficulty breathing are the commonest symptoms in adults with COVID. Fever occurs almost in most patients at some stage within their disease, but is not always present at the initial stages. And this is why, although many of us, and there's lots of talk about using temperature screening to screen for COVID, it's probably not a very sensitive tool. And my other argument, I suppose, against it is I think that as adults, if we have a temperature of 38.5 or 39, we will know we have a temperature of 38.5. And, you know, you can't have a high fever as an adult and not know that you're having that symptom. Respiratory symptoms are very common in the adult population: fatigue and muscle aches, because this is a viral illness and gives you a viremia. Loss of smell or taste, really interestingly, seems to be, is definitely a feature of COVID, and typically a feature in otherwise healthy, relatively young people. So there is a cohort of people whose only symptom is this loss of smell and taste. And in those people, about 2/3 get full recovery within 2 weeks. Skin rashes is evolving. I mean, if we're, you know, it's a whole other day to talk about COVID in adults, but COVID in adults is an extraordinary illness. It presents in so many ways that we really don't fully understand, but certainly skin rashes are a feature, and we're getting more and more understanding of that. And gastrointestinal upset is quite common. About 20% of adults and 10% of children will present with significant nausea, vomiting, or diarrhea, and that's much more common in COVID than it was in SARS or the Middle Eastern respiratory syndrome. And I'm going to talk briefly about the multisystem inflammatory syndrome, which is a pediatric syndrome. So this is just showing us some of those skin manifestations. You may have heard about COVID toe, which is this kind of concept of these very painful red toes, which are a feature of COVID. And I think when you talk to people in general practice, they'll say that they were seeing some of these unusual features way back in January and early February before we were confirming COVID. And now we're wondering, was some of that early presentation of COVID-19 that was undiagnosed? So in children, this is from a meta-analysis just published last week. So in children, 16% are asymptomatic. So again, not this huge asymptomatic carrot that we had heard about. 37% mild, 47% moderate, 3% severe, and 0.6% are critically ill with COVID. This is nice data from China, again confirming that less than 1% of all cases in China were in children under 10 years of age. It's case years of 171 children, 16% asymptomatic, and as expected, they'd cough, fever, and red throat were the commonest symptoms. You can see that only 40% of the children had fever, so again, not a very good screening tool if you're thinking about using fever as screening in schools. And they had 3 out of those 171 children were admitted into intensive care, and they all had pre-existing conditions. And there was 1 death. So the death was in a child who had interception, so that's a surgical condition, and that child then ended up having multi-organ failure, possibly related to COVID or possibly related to the underlying severe surgical emergency. So I think to think about the really important piece about what about the children with complex medical needs, what information do we have about this cohort of children? And I'd say it's not huge, but I'll go through what the data that we have to date. So I put this in because Stephanie, who is going to join our panel, sent me this headline. She saw this on Twitter. So COVID-19 kills children with intellectual disabilities at high rates. Here's why, and that's a very dramatic newspaper headline that would cause fear among the parents of children with intellectual disabilities. But when you actually trace back, this article is talking about this newspaper article is referring to this journal article, and the journal article is vague and gives very limited details. So it talks about the fact that it's taking data from a huge database of people in America with intellectual and developmental disability, and what they've noted from that is that 2 out of 125 people on this database died with COVID-related illnesses, but there is no more detail of what comorbidities those children had or their course of illness. So it's really hard to interpret that data, and it's pretty poor quality. So I think just kind of the reason I wanted to include that was to kind of say that we need to go behind the newspaper headlines and really try and examine where that information has come from. This is data from Italy. So initially when we started hearing about COVID and we heard about it in China, people were very worried about children, and we kept saying, well, we can't really, they don't have children with complex medical needs and life-limiting conditions in China. It's a very different population. We can't really compare Chinese data with Irish data. And, maybe it's different. Maybe it will be different when COVID comes to Europe. And this is then data from Europe, and I think, certainly in Italy, that have similar population, childhood population than we have. So again, really low numbers of COVID cases. 27 children in this paper had comorbidities. 9 of them required respiratory support, and they don't detail what that respiratory support is. So that may just have been oxygen. They don't talk about whether it's oxygen, non-invasive ventilation, or ventilation. And they said that 6 out of the 9 children who required respiratory support had pre-existing comorbidities, but didn't talk about that. But they had no deaths in children with COVID out of this paper. This is an interesting paper coming from Birmingham Children's, and they examined children presenting into the hospital with symptoms, potential COVID symptoms over a 3-week period between the middle of March until the beginning of April. So the time when there was really high rates of COVID in the general UK population. They tested 389 children for COVID, and 45 of those children were positive. Out of those 45, 44% of the children met the UK public health criteria for extreme vulnerability. So children who were either on chemotherapy, radiotherapy, had a recent organ transplant, had severe respiratory illness such as CF or severe asthma, or were on immunosuppressive drugs. And out of that cohort of 45 children, only 20% required oxygen support. 3 children required high flow oxygen or CPAP, and only one child required invasive ventilation, and that was a child with severe congenital heart disease, and they had no deaths out of their cohort in Birmingham Children's. This is from Great Ormond Street Hospital. Again, so we're talking about a population of children who are referred in. If you remember, Great Ormond Street does not have an emergency department, so they only admit children who are referred from surrounding hospitals. And so they looked at the children within their hospital, again, this is over a 6-week period, who presented with symptoms consistent with COVID. They compared the vulnerable cohorts of the children with pre-existing medical comorbidities with children who didn't have those pre-existing vulnerabilities. And they noted and concluded that the vulnerable children, so children with pre-existing medical comorbidities, were less likely to be COVID positive than children who were not. That children with medical comorbidities who are COVID positive were not at increased risk of respiratory illness. And they didn't attribute any deaths in that, over that time period, to COVID. Now, one child who was COVID positive died, but the cause of death was stated to be a pneumonia, an aspiration pneumonia. And importantly, in the same period, 4 children who had medical comorbidities but weren't COVID positive died. So they were really saying that there's a high rate, that these children are at high risk of acute health deterioration at any stage, and not necessarily COVID. 3% of all inpatients in Great Ormond Street at the time had COVID-related illnesses, in comparison to 25% of inpatients in the surrounding adult hospitals. And they state within this article that the criteria for shielding, they say, because that's the UK term, in adults may not be applicable to children. So this is what's starting to come out through the data. And then the final, I think, relevant article is an article from the US looking at children within intensive care units over a 6-week period, again, through the height of the pandemic in the States. So this is a really big, this is a study covering 46 intensive care units across the US and Canada. So it's a really important study. Over that 6-week time period, they only had 48 children admitted to PICU with COVID. Of those, you see that 19 of those children were children that we would consider medically complex. So these are children who have developmental difficulties, who are dependent on technology for their survival. So they're medically complex children. And 38, so 82% required respiratory support. They're talking about oxygen or increased in their previous ventilatory support. 38% required invasive ventilation. And 2 children out of these 48 children died. Those children were older. There was a 12-year-old and a 17-year-old. And one of those 2 children actually was in hospital with a gram-negative sepsis at the time that he acquired COVID. And so, you know, again, a very unwell, medically fragile child who did have COVID and died. But they make the very important point, there's 2 important points in this article. This is the first one, is that the mortality of children with COVID admitted to intensive care units is 4.5% from their data, compared to a mortality rate of 60% in adults who are admitted into intensive care. And then they make this really important point, and I think this is probably one of the take-homes of today, certainly something that I've taken home, is that in the USA, up until this article was published in May, they had 8 childhood deaths across the US from COVID-19, and there was 169 childhood deaths from influenza in the same period. So we need to, so again, no evidence that children with complex medical complexity are at higher risk of severe disease from COVID versus the respiratory viruses that they see every day. So I'm just going to, this is just something brief about this SARS-CoV-2 related inflammatory multisystem disorder, which is this newly described Kawasaki-like syndrome. So this is a really newly described syndrome, and it refers to children who present with persistent fever, blood signs of ongoing inflammation, and signs of either single or multi-organ dysfunction. And in the majority of cases, these children may either initially test positive for COVID or may show immunity to COVID, so they have had pre-existing contact with COVID. And importantly, the piece that people are very concerned about in this population is that a subgroup of them have cardiac failure, have really significant cardiac failure and require huge levels of intensive care support. The UK data is described 58 children. There's some data from the States which describes 20 children with this syndrome. Importantly, all of the children who are presenting with this pediatric inflammatory multi-system syndrome are children who are previously well. So this is not occurring in children with medical comorbidities. These are previously well, healthy children who present into hospital acutely unwell, collapsed, requiring high levels of intensive care. It's very similar to Kawasaki. It's similar but different to Kawasaki disease. They tend to be older than the typical children from Kawasaki disease, but the treatment at the moment is very similar to that treatment of Kawasaki. So this is, I think, something that we are learning more about every day. I think we've had 7 potential cases in Ireland, not fully understood. The treatment, not quite clear what the treatment is, but I think is not relevant to children with severe disability. So last two questions. So the first one, when should I wear a mask in clinical practice? This just keeps changing. I would refer to the HSPC guidelines, and certainly within the hospitals and within Lower Lynn, we are following this guidance that we're wearing surgical masks when we are providing care to a patient, if we're within 2 meters of a patient, or if we feel like we can't be socially distanced with colleagues. In the hospital, we're wearing masks for all patient contacts. So when we're doing our face-to-face clinics, which have restarted, we wear a mask in that clinic setting with the patients, and we ask parents, not always the children, but the parents, to also wear masks. And on ward rounds, we are also wearing masks. And I think we can talk a little bit about that in the panel afterwards, about kind of the use of masks in the community. Because I think there's still a lot of lack of clarity. And then my last, is should I wear my homemade mask to Aldi? So I added this picture. I think if only I looked this stylish when I was going to Aldi, I wouldn't mind wearing my mask. But I do wear a mask when I go to do my shopping. I wear it because I believe that I am protecting others, and I also wear it because I think that I am a half-sane person, and that if relatively young, healthy, sane people wear masks when they are in the supermarket, we will normalize this behavior. So this is a mask that my friend made for me, and anyway, embarrassing picture. But this is the evidence. So the evidence is that masks, community masks, so these are they're not masks, they're face coverings, and they can be anything. They can be a t-shirt, they can be a scarf, they can really be anything, and have some impact on the spread of COVID within a community. So this is data just looking at, the countries where they have been successful in managing the pandemic in the community are countries where people wear a mask. So particularly if you look at South Korea and lots of other areas of Asia where people, post-SARS, people have been very used to wearing masks, they have lower rates of community spread than in countries where we don't wear masks. And I would direct you to the Masks for All is a group and a website with lots of the evidence around this, and there's lots of chat on Twitter. So that I got this very nice photo, not of me, but the photo of these very glamorous women on Twitter this morning from Trisha Greenlaw, who is one of the an Oxford professor who's working very hard to really promote the use of masks within the community, and showing us that in the influenza pandemic of the 1918 and 1919, that people wore masks quite broadly. So I think hopefully in that 34 minutes, I have shown you that COVID-19 is real. I hope that I have shown that the evidence tells us that children are less frequently and less severely affected with COVID than adults. I hope that I've convinced you that children are not super spreaders. And and that we can maybe really think about as a society, freeing our children up from their incarceration at home. And that children with complex healthcare needs, they might be at higher risk of severe infection from COVID, but that risk is no higher than from any other respiratory virus. So this is a cohort of children who are at high risk of having respiratory deterioration from any respiratory virus, but that COVID is no worse than influenza or any other respiratory viruses. And these, I think, are two really good resources. If you haven't never heard of or have never looked at Don't Forget the Bubbles, I would highly recommend that you do. This is a group of international group of pediatricians who look at kind of evidence. They kind of create not simple, but relatively simple kind of evidence base for a number of conditions, and they've done lots of work around COVID and done some really nice evidence summaries of the COVID-19 literature. And then this was actually published yesterday from Sick Kids in Toronto, and talks about the recommendations for schools reopening. A really nice paper. This being, I think, something similar in the UK. I'm really hoping that we're going to publish something similar in Ireland. But this is kind of what's within this is good, sensible guidelines that I think is very user-friendly and worth a read. So I've used this Friends font here because I did think when I was preparing this about how lucky we are in healthcare to be able to make friends, and I've been so lucky that I can actually, I have friends, colleagues who are also friends that agreed to come onto this panel when so we're going to open up for questions